it's already going to be a cluster, and if you try to change a machine and do all of this stuff, it's just going to slow down the treatment. So while they're getting the cart, we shut the anesthetic off. We're hyperventilating the patient with 100% oxygen. If you do not have a secure airway, you probably want to intubate the patient. You don't need to. This patient had an LMA in, and they seemed to think that they were adequately ventilating him. I'm not sure that they were, but definitely want to hyperventilate with a secure airway if you can. The next thing on my list is getting the dantrolene ready. And, you know, so the first thing that's in here are just IV starts. And so if you have plenty of people, you know, you might want to get a couple of extra IVs. If I'm leading this, I'm going to be the leader, and I'm going to designate a reader. So I'm going to have a leader, a reader, and some doers. And the next thing we're going to do is mix some outdated. You want to do it for me? Sure. If you think it's hard now, wait until you see how hard it is when it's actually happening. So we're going to, we have the form of dantrolene that is considered the new form. The old form was 20 milligrams per vial. You had to put 60 cc's of sterile water in. And you had to mix typically 12 or 13 of them in order to have a single treatment. And you'd have 36 bottles of the stuff, 20 milligrams per bottle. And the patients would get anywhere from 800 to 1200 cc's of sterile water, which isn't good for you, but that's what it took to mix it up. And you actually had to have 2 people mixing up dantrolene. With the Ryanodex, it takes 5 cc's of sterile water, preservative-free, no bacteriostatic, and you can mix it usually in a minute or less. And after you put the sterile water in, you've got to shake it up until it turns clear and orange. And when it's clear and orange, it's ready to be used. And the normal starting dose is 2.5 milligrams per kilo, which is, that's got 250 milligrams. And so you'd use, you know, 3/4 to a whole bottle. For a 100 kilo person, you'd use the whole bottle. 70 kilo person, you know, 3/4 of it. And that is the antidote, if you will, to malignant hyperthermia. There isn't anything else out there that actually treats the condition. There are other things that you need to do to treat some of the comorbidities that occur with malignant hyperthermia, but that is the true antidote. And it's given intravenous push. As soon as you give one, then you mix up another one, because it's not uncommon to need to give a second dose and then a third dose. You know, if this thing goes on for 30 minutes or longer. The thing that happened with this kid again was that he probably got a slow diagnosis, and it's not the high temperature that kills you. It's actually typically a high potassium that kills you. So he had went from a normal sinus rhythm to a sinus tachycardia, which is also an early sign of a problem with malignant hyperthermia. Even if the temperature is normal, they'll develop a tachycardia. And then they'll usually have a potassium of around 10, and then they'll fibrillate and die. And that's what this kid did. So one of the things after you've given the dantrolene is you want to do something to get their potassium back down. And so in drawer number 3, we should have, no, yeah, drawer number, well, I guess they're in here. We have, we don't have everything we need in here. Interesting. To get the potassium down, you know, you need like D50. You need
Yeah, the insulin.
It's in the regular
It's
crash cart.
the insulin is in the fridge.
So insulin's here, glucose, calcium chloride, bicarb. And if you do those things, you can also do albuterol inhalers that lowers the potassium fairly quickly. But those are the things that we would typically want. And so if they're not in here, we're going to get the regular crash cart also, because we need to get the potassium down quickly. Otherwise, they are very likely to fibrillate and need to be resuscitated from a cardiac standpoint, in addition to a malignant hyperthermia standpoint. Actively cooling. So we have in the anesthesia refrigerator bottles of cool lactated ringers. We're going to get saline, but right now we have 4 liters of that. That's the best way to cool somebody, is internally. You can pack them in ice, and we have an ice machine here that we will probably do both, but initially we're going to hang cold IV fluids. We're going to get some ice and pack the patient in ice. The problem with packing them in ice and externally cooling them is that they have a tendency to form a cool shell, and the inside stays warm. And you know, there are reports where the body temperature has gone up over 108 degrees, and the protein in the brain actually congeals like egg white. And then you're pretty dead too when that happens. So we want that not to happen, and we will cool internally and externally. You can pass an NG tube and flush with cool fluids. You can put a Foley catheter in and flush catheter with cool fluids. So there are any number of ways to internally cool, but the easiest, quickest, best way is just with iced IV fluids. Next on the list, acidosis. We already talked about using some bicarb. Treating arrhythmias, again, we're going to want to have the crash cart in there, because I know that there isn't any amiodarone in here. There is some lidocaine in here, but it's, you know, kind of a second tier arrhythmia drug, and amiodarone is thought to be a better drug for treating arrhythmias. Maintain urine output, so we are going to put in a Foley catheter. The old dantrolene had I think 360 milligrams of mannitol in with it. The new only has, like, I don't know if it's 15 or 50, but it's got some mannitol in there, but it's a small amount compared to what the old dantrolene had. But you also need to keep the kidneys flush, because if they have malignant hyperthermia, they're also going to start breaking down muscle tissue, and broken down muscle tissue has a tendency to cause kidney failure. So we're going to want to monitor urine output. Ultimately, we're going to need to figure out some kind of disposition for the patient. We cannot take care of them here, and so chances are while most of this is going on, we're going to talk about sending for an ambulance, getting an ambulance crew here, letting the receiving hospital know, you know, what we've got, what we've done. Chances are I, as the leader, would go with the patient in the ambulance, because this isn't like a, you know, an elective transfer post-surgery. This is the real deal. Admit to the ICU. We obviously can't do blood gases, electrolytes, or any of that sort of stuff here, but anyway.
What
So-
would be a time of, like, if it does happen, where you would say, okay, now we're safe to transfer?
Well, supposedly, if you get the potassium down and they go back into a sinus rhythm, and their blood pressure stable and their heart rate stable and their temperature is dropping, you don't have to have it drop back to 37. You know, they say as soon as you drop 2 to 3 degrees that you ought to stop cooling, because you're going to probably overshoot in the other direction.
Right.
And some people fibrillate when when they get too cold, and so you don't want that situation. But with dantrolene and probably some background amiodarone or something like that to prevent further malignant arrhythmias, I think that it'll be obvious to you when they're there. You might end up giving a second dose of dantrolene, just to be sure, before you actually transport. So,
But still, don't hesitate to call 911, get them here, and then
yeah.
the anesthesiologist would decide
And,
when it's
I mean,
okay to
chances are
transfer.
You're not going to transport them until we're either done, or else until they're done. Medium rare. But
Hopefully not.
I wouldn't transport an active resuscitation from the OR into an ambulance. That's a disaster. This kid actually went then back into a sinus rhythm, but sinus tach, and the second time he arrested, he went asystole, which is pretty uncommon, but anything can happen. So I think when they transported him, he was asystolic and got an external chest compressor, and never survived the event.
And then we would, even drugs or whatever, we would also want the crash cart to come, because we don't have a
Yes.
defibrillator,
Yeah.
obviously, on the
I mean,
cart.
if you do this quickly enough in the first 15 minutes, you probably won't have anything other to do than the dantrolene and maybe some internal cooling, and securing an airway and hyperventilating with 100% oxygen and finishing the surgery. But
Okay. Does anyone have any questions? Okay.
It's not malignant hyperthermia, and you treat it if it's not malignant hyperthermia, what side effects would it have?
the only bad thing that dantrolene does is it kind of causes weak muscles. There are people that take oral dantrolene for spasmodic conditions, not cerebral palsy specifically, but stuff like that where they're spastic. And so, I mean, it causes muscle weakness, and it has been given to MH susceptible patients preoperatively orally, and they get a little weak in the knees and that sort of thing. It's been given to non-MH patients who are thought to be MH patients, and they do fine. I worked with a guy in Omaha who he would treat any fever of unknown origin, including somebody that have a fever from a gangrenous gallbladder in the OR. He'd give them dantrolene. I mean, that's overutilization, but I guess you'd rather have somebody with an itchy trigger finger rather than asleep at the wheel. but it's pretty clear that a gangrenous gallbladder causes a fever, and patient probably doesn't need it. But there's not really a whole lot bad that can happen by giving it. What else? All right. Thank you.